It is just a huge honor for me today to be podcast interviewing Mike Racich all the way from my favorite city in North America, Vancouver, British Columbia, Canada. That is the coolest damn city. He's a 1982 graduate from University of British Columbia, has a general dental practice emphasizing comprehensive restorative dentistry, prosthodontics, and TMD orofacial pain. Dr. Racich is a member of many professional organizations, current AES Past President, and has lectured nationally and internationally on subjects relating to patient comfort, function, and appearance. He is a fellow of the Academy of General Dentistry and the American College of Dentists, as well as a diplomate of the American Board of Orofacial Pain and the International Congress of Oral Implantologists. Dr. Racich has published in peer-reviewed journals such as the Journal of Prosthetic Dentistry and the International Journal of Periodontics and Restorative Dentistry, and has authored the books The Basic Rules of Oral Rehabilitation, The Basic Rules of Occlusion, The Basic Rules of Facially Generated Treatment Planning, The Basic Rules of Being a Dental Patient. Currently, he mentors the didactic, clinical focus, dental education continuum, study clubs, proprietary programs, coaching, second opinions only in Western Canada. Man, you are so accomplished, and I wanted to get you on this show so bad because this is Dentistry Uncensored, so let's get
Let's do it.
Let's get raw. The bottom line is these kids come out of school and they say they didn't learn much about TMD or occlusion or facial pain, and they want to learn more, but it seems the kids tell me, and remember, we're on a podcast, so it's all millennial stuff. All the baby boomers are reading your textbooks. The millennials only read books if they're audiophiles, but anyway, if they went to 10 endodontic lectures, there'd almost be no controversies. They went to 10 pediatric dentistry courses on a pulpotomy, there'd be almost no controversies. And they're like, man, these occlusion camps are like world religions. Do you agree with that assessment, or is that not the real reality?
I think that everybody means well. And I think that everybody is out there, the various institutes or the camps or whatever you want to call them, and they're basically trying to tell the information and simplify it as best as they can. And that's what prompted me to write my first book, is The Basic Rules, because what I realized is that no matter whether you've got one group talking way over here and another group talking way over there, at the end of the day, they're all talking about the same thing. And essentially, that's what my first book's about, is just trying to distill down everything into simple, practical terms. For example, you mentioned endodontics. I mean, success with endodontics is not obturation. It helps to do good obturation. Success with endodontics is cleaning it out. That's the basic rule. So there's basic rules with occlusion and TMD and all that sort of thing. And I think that nobody is doing, I call it institutitis. There's a noun form of institutitis and a verb form. And I'm a general dentist, and as a general dentist, I was guilty of institutitis too. I went to a continuum, and that was the noun form where of course I have to learn it, and so I listened to what the instructors had to say, and I gathered as much information as possible. When institutitis becomes dangerous is when it becomes the verb form, and when somebody puts on their blinders, and as you say, they live the camp, and they fail to realize, and they stop to realize that there's more than one way of accomplishing something. To put it another way, I never, ever knock success. So if I can see one group over here having success and I have another group over here having success, and they appear to be doing things differently, well, wait a second here. There has to be some common variables. And I think at the end of the day, for the people that are listening to this, the millennials, as you say, and they want to get started, go get started. Take somebody's program. But don't drink all the Kool-Aid. Remember that, take the good information and then go listen to someone else that you think might be diametrically opposed. And just sit back and listen and try to think to yourself, what are some of the common elements? I mean, if you want, you can purchase my book, of course, or give me a call anytime. But that's not
how would my homies find your book right now?
Well, it's on my publisher's Palmieri Publishing. They're a Toronto-based company, Markham, Ontario. And it's palmieripublishing.com, or they just go on my website.
Your website is drracich.ca?
Yeah, and you can just go on the link there. But that all being said, let's go back to your question.
No, I want to sell some books for you.
Well, I want to sell them too, but the main message here is go out and learn it, but eliminate the blinders and try to keep open-minded.
Trying to find okay, now I found it.
Yep.
Publications.drracich.ca. You told me something interesting. that your name, Racich, that you're Croatian, and the first C in a Croatian name is pronounced an S. So
Yes.
it's Dr. Racich, but he's Croatian, so it's spelled DRRACICH.ca. And you have all 4 of your books there. What one would be there? First of all, are these books in audio?
The books aren't in audio yet. Books number 2, which is Occlusion, and book number 4, The Basic Rules of Being a Dental Patient, are now being translated into Polish.
Nice, nice. You got some Polish friends?
Yeah, that, and I've lectured over there, and I'm going again this summer to lecture. So it's a little preemptive move to try to.
Do you know Marcin Didactic?
Not yet.
Email me, howard@dentaltown.com, and I'll reply back with Marcin Didactic. He's the godfather of dentists in Warsaw. He's the most connected man. He's the most lovable guy. But yeah, Amazon says that audiobooks are outselling textbooks, and I came out with my book, and it was a hardback book, and sales are doing great. But I finally one day sat down on Skype and read my entire book for 5.5 hours, and the audio version blows away the print.
It's a good suggestion, and I'm on it.
Yeah, because it's kind of like I thought it was weird that movies and music were separate. They were silent movies and music separate for 40 years before one human put the deal in. And then the next thing to come along was add popcorn, because monkeys are too too hyper to sit there and just watch a movie, so they got to eat while watching a movie with sound. And you would be surprised at how the millennials, when they read books, they like to be commuting to and from work, an hour on the Stairmaster, a long bike ride, and just everything. But I don't want to get you in trouble, but I feel like I'm going to get you in trouble right now. Their specific question is, they can just go to any endo course. They can go to any pediatric dentistry course. But they feel like they got to pick between like neuromuscular or CR, and some of these courses also promote expensive toys, maybe $18,000 worth of equipment, and they're like, I'd like to learn this faster, easier, higher quality, but lower cost. Do I need this? So answer that round of questions. Or are you going to piss off all your friends? Are you going to have to move to Croatia after this podcast?
Like I said, I think everybody's out there giving very, very good information. Just remember, there's a noun form of institutitis and a verb form. And I think that everybody has to be very careful that they don't get locked into a camp. Keep an open mind. All education is good. I would encourage any and everybody to go out and seek and go and listen and keep an open mind. And of course, I've written 3 books. I've distilled things down. Obviously, if somebody wants to contact me, I coach, I lecture, blah, blah, blah. I'd be more than willing to share my information and how I think that there's more similarities between all these different groups than there's not. So, for example, you mentioned myocentric and you mentioned traditional CR. Well, at the end of the day...
So just for the kids, myocentric, you're using that interchangeably with neuromuscular?
Exactly.
So you can basically split the whole occlusion world into 2 just by saying myocentric, neuromuscular, and CR. Is that oversimplification?
It's a good It's an oversimplification, but it's a good one.
Okay.
Okay.
You got to remember, my brain is only the size of a walnut, so you got to go slow.
But yeah. Well, you and me both. But CR, no, it's myocentric and centric relation. There's more similarities than people think there really is, because at the end of the day, what the restorative dentist has to achieve at the time of definitive records, is a consistently reproducible position. So I call CR not centric relation, I call CR consistent reproducibility. So whether someone's using a myocentric technique or a neuromuscular technique or a traditional CR technique or whatever technique, at the end of the day, the dentist has to have a reproducible position that they can treat to. And that's really distilling it all down. That is the basic rule. That's like cleaning out the endo tooth. That's the most important thing. Get it in as clean as possible, and then we can obturate any way that we want to.
I really like that. Centric relation CR to you means consistent reproducibility. That's very, very cool. But in that consistent reproducibility, all that stuff, some people go back and think there's a brain activity to all this, and that it's not so mechanical. And then some of the elder statesmen like Dawson says that's not true. It's all mechanical, and some are saying it's all some of it's coming from the brain.
Oh boy, you're just walking into these questions beautifully for me.
Am I?
Oh, I'm loving this. I'm loving this. When I teach occlusion, because my focus study clubs are didactic and clinical, what we mean by that is we meet all day and there's at least 4 or 5 hours of hands-on. Okay, so when I first start working with a group of dentists or a dentist, I always tell them 50% or more of the occlusal equilibration is done in the consultation room. 50% or more of the occlusal equilibration, or for that fact, restorative dentistry or prosthodontics, is done in the consultation room and not chairside. It's all about discussing things with people, educating with people, getting that so-called placebo effect with people, building that trust, and so on and so forth. How I can guide a mandible is not, sure, it's a mechanical guiding that we do, whatever technique somebody wants to use. But if the person is sitting in the chair bolt erect, good luck trying to get any kind of position. The more relaxed and more confident the person is with us, the more that we're able to work with them, educate them, they're listening to us, they trust us, and so on and so forth. So at the end of the day, yes, it's a mechanical thing that we're doing. There's various techniques that can be shown, but it's getting in line with the patient, and most importantly is finding out what that patient wants. So for example, when I'm guiding a mandible, and if a patient's telling me that I'm pushing them back and they don't want to be there, hello, they don't want to be there. So I have to then develop a technique or work with that patient to get them into a comfortable physiologic position that's not only mechanical, but it also works with the what's going on upstairs here with the patient as well.
I do, when they don't want to put the mandible back, I do the United Airlines approach, just start beating them and drag them out of the operatory until they do what I say. Do you recommend that? Or does that not fly in Canada? Is that something that only happens in Redneck, Arizona?
You know how it is, you know.
Well, back to selling your books, because, my job is to, I think the most successful dentists that I watched in my 30 years were the ones who... And that's why we're doing a daily podcast show, and I'm trying to motivate them to read your books. A great way to read books is we put 470 online CE courses on Dentaltown, and they're coming up on 1 million views. And if you put a 1-hour course on this, it would build your brand, sell those books, fill your classes. I would give anything if you do an online CE course.
Yeah, I'm in.
I'm in. You talk about the hierarchy of dental care, levels 1 through 6.
Yeah, that's an important one. The basic level is the elimination of infection and pain. The level 6 is, okay, inter and multidisciplinary dentistry are two different terms. Interdisciplinary dentistry means within the profession. Multidisciplinary dentistry means dentists, physical therapists, dermatologists, neurologists, plastic surgeons, and so on and so forth. So that the top level is level 6. So level 6 is really being, as I think, I don't know who coined this, maybe it's an old expression, but it's being a true physician of the mouth. In other words, we're treating the whole person and not just the tops of the teeth. And so that's, and really, I haven't listened, unfortunately, to any of your podcasts. Sorry, Howard.
No, that's fine.
I'm pretty certain that someone's probably spoken to this, and that one of the places that dentistry is going, it's going quickly, is into patients want more than just their teeth fixed. They want to go to offices that are looking at maybe what their diet is, what their diet composition, maybe give them some diet counseling and other things to give them a more broad medical dental-based model of care when they walk into their offices.
But what would that term be? Because you said interdisciplinary was within dentistry and multi-specialty was the whole body. Is that what you said?
The whole body and all the other different specialties.
But it seems like the consumers call that holistic. But when you say the word holistic to a dentist, he thinks you're a quack and runs out of the room.
You notice how I try to avoid that statement when I just gave you that explanation?
Yeah, I know. I mean, people who put on their website holistic natural dentistry fillings without any GMO modified, whatever, they get patients driving an hour away. But the dentist would think of their peer as a quack. I mean, so the consumer worships that word, and the dentist thinks it's quackery. So what's your word for holistic?
Whether a dentist markets himself, outside externally that way, or just internal marketing, I think that a dental office that embellishes multidisciplinary care, in other words, they network. Their network just isn't endodontists and orthodontists and everything else. Their network, whether they want to do Botox or not, for example, is plastic surgeon and dermatologists. Their network is, if they're doing TMD and orofacial pain, is neurologists and other people like that, physical therapists, massage therapists, and so on and so forth. So at the top level of dentistry is multidisciplinary care, inter and multidisciplinary care. At the beginning level is what we were taught in dental school, elimination of infection and pain. Level 2 is simple treatment. Again, we all graduate knowing how to do that. Level 3 is we're now trying to treat sextants and quadrants. So, most of us can get to that level in 5 to 10 years quite comfortably. Some of us are more talented, get there a little faster.
Now, sextants and quadrant, is that metric or is that imperial math? You're going to confuse all the Americans. They're like, wait a minute, is that a metric term?
It's all the same. Well, what I always like. Well, no. What I always like to say is oral surgeons think in inches, orthodontists think in millimeters, and restorative dentists and prosthodontists think in microns. In terms of
say that one more time. Oral surgeons think in
inches, or feet sometimes. Orthodontists think in millimeters. And then lastly, restorative dentists and prosthodontists think in terms of microns.
Nice.
And that's what, at the end of the day, when we have an occlusal problem, trust me, it's not millimeters, it's usually microns, as we've all been down that road. We all know that one really well. So then level 4 is basically what the institutes can help people do. And that's, they can treat, complex aesthetic restorative dentistry, not in maximum intercuspation or habit bite. Maybe they've learned a joint position. And it kind of goes back to our discussion that we had earlier. This is the level 4. Level 5 is what we'd consider interdisciplinary dentistry. So the dentist is now moving past the institute, or maybe the institute is encouraging them to go to work with orthodontists and all that. But the dentist at level 5 is maybe starting to bring in other concepts like I tried to talk about earlier, not just the one institute, but get other people's ideas. And then they're really branching out to try to look at their cases and definitely encouraging, the other dental disciplines to be involved. And then, of course, I mentioned level 6.
What do you think of the current use of the term evidence-based dentistry? Do you think it's a good thing that has a long way to go? Do you think it's misunderstood? What are your thoughts on evidence-based dentistry?
Yeah, evidence-based dentistry. There's, we're all practicing evidence-based healthcare. I'm 60 years old right now, and I'm having a few medical afflictions now, and I practice evidence-based healthcare. I go on the internet, but I just don't go on the internet. And for all our colleagues that are listening right now, we can go on Google and just type in some keywords. But it's just so simple. I mean, there's so many medical databases out there. And of course, the easiest one to get first involved in is PubMed. All we have to do is go on, whatever we want to use, Google or Yahoo or whatever else, type in PubMed. And then in comes this Library of Congress or whatever it is, the Health Institute or whatever it is. And then all we have to do in the search box, because they've made it really easy, and all we have to do in the search box is just type in the key terms. And the most important term to type in is review. So for example, if I want to find out about a new composite material, or what type of white material I want to use, all I have to do is type in composite, review, and hit the button. And a whole host of pretty decent articles are going to come up that people have taken the time to sit down and think, and then maybe they've been peer-reviewed. I'm not saying that there's anything wrong with anecdotal and articles that are written as editorials and all that. That's all good learning. But if somebody really wants to look at the evidence and and look at articles that at least somebody's tried to sit down and maybe do a meta-analysis on or a statistical analysis on. It's a simple way of doing it, but that's not the main point here. The main point about evidence dentistry is not the evidence. Evidence-based dentistry is three-part, and I have this actually in my book. It's actually a Venn diagram. You've got the Venn diagram is those three little circles, and one of the circles is evidence. The other circle is the team values, the dentist values, and the third circle is patient values. So 2/3 of evidence-based dentistry has got nothing to do with the evidence. 2/3 of evidence-based dentistry has got to do with patient values and dentist values or team values. And if these two aren't in sync, then who cares? But that's just common sense. I mean, it doesn't matter what level of dentistry or what anybody that's listening to this thinks of this, or they've got the ability to access it. If we do not get along with our patients, and our patients don't understand us, then what's the point of going forward? It doesn't really matter what the materials or what the so-called experts say at the end of the day. It really comes down to the 2/3 being in sync before we even look at the evidence. So when I practice evidence-based dentistry, Howard, the first thing that I'm trying to do is connect with the patient. When a patient comes in for the first time and meets me, the first thing I'm trying to do, and our team, of course, because it's a team, they're just not meeting me, by the way. It's a team they're meeting. When they first come in and meet the team, the whole idea is to try to get this little mojo working, that the patient will feel comfortable and give us honest answers, and will listen to us, and we can get open to this line of communication. Then and only then do we really look at what the evidence is saying. And there's a hierarchy of evidence too. The review articles, like I tried to suggest, are a good way to go, but it goes all the way down to just expert opinion too, which there's nothing wrong with. I mean, it's all good information, but we have to temper it as to which way we might want to lean a little bit more when we're looking up some information.
So let's do summaries of your 4 books. The Basic Rules of Oral Rehabilitation.
Yeah.
Summarize that. How long would it take to read it? 6 hours?
That could be read. It depends. It could be. The books were written deliberately short. Each chapter, each rule was written 1,000 words or less, and they were written and with only 10 references, and they were written to be a very quick overview of the subject. But they're also written in layers, because as you know, you write, and as you know, we can use a lot of terms to solidify a lot of concepts. So in one sentence, I could maybe write a concept down that maybe could be expanded easily into a chapter in a book. And so depending on the sophistication of the dentist and how deep they want to go into the books, those books could be read in an hour, but then a person could go back and spend, a long time reading certain aspects of the book and thinking about it, and then maybe going to do some research on their own.
Summarize the basic rules of oral rehab, can you, or is that an unfair question?
That's right. It's just straightforward. It's broken up into sections. It's called the patient, the plan, the process, the payoff. So the basic rules of oral rehabilitation is broken up into 4 sections. The patient,
plan,
the process, the payoff. The patient is the patient, kind of just what I was talking about when I was talking about evidence-based dentistry. Get to know your patient, placebo, all that sort of stuff. The plan is the plan. We have to have some kind of sequential way of going through, introducing a patient into our practice, and then working through whatever way we're going to sequence through. The process is the process. In other words, how do we go from A to B? In other words, taking records and all that sort of stuff. And then the payoff is the payoff. You know what the payoff is? Being able to go to sleep at night.
Nice.
It's priceless. The payoff isn't making $30,000 a case. The payoff is making some money, paying our staff, and then being able to have a good night's sleep.
Let me make an analogy. Like if when people start getting into endo, the endodontists say, start off as incisors. Maybe then work your way to bicuspid. Don't start with second molars. Orthodontists say, you don't start with a high angle, long face. What basic rules of oral rehab would you tell these young millennials when they get started to stay out of trouble? What are red flags that say you need to be 5 years down your journey before you start doing that? Are there any of those that you can think of to keep them out of trouble?
Oh yeah, definitely find out what the patient wants, and always ask the patient what they want. So, for example, I'm going to do a posterior crown. First question I ask him is, do you want a metal biting surface or a white biting surface? White biting surface. Do you want a layered porcelain over metal or a high stress zirconia core? What's the difference? They both can chip. If you don't want to you want to minimize the potential for chipping, then maybe you just want the high stress ceramic core. And then I look at the patient, I let them make the decision. If it's talking about a more complex case, I say to them, are you interested in orthodontics? No. So then we have to explore something else. If it's maybe an implant case where they're edentulous in the maxillary posterior and there's minimal bone, crestal bone height, I say to them, are you interested in potentially doing some bone augmentation in your science? Yes, no. If they say no, the door gets slammed, and then we have to think of another opportunity. So I'm always encouraging, I'm always asking questions. Now, the questions I just gave now weren't good questions because they were yes and no. They were closed-ended questions. They weren't open-ended questions. I would recommend that always ask questions that's elicits a response more than yes or no. It gets the patient talking about what they really want. So the first step with everything is to get the person's consent, their informed consent. That's a medical legal term, but it's just common sense. Get the patient talking and find out what the heck they want. And then we have to know what we want to do before treatment, but most importantly is what are we going to maintain this patient lifetime? I'm 60 years old. I probably got another 10 years left practicing. I've already cut the practice down. I practice a couple days right now. But you millennials out there, you've got a few decades. And with the communications ability of people nowadays, the patients are going to find you. Okay, you might be practicing in Seattle, Washington right now, and you might move to Paris, France. But guess what? They're going to find you. They're going to find you. And so at the end of the day, what are we going to do, and how are we going to maintain that case, no matter what we do, whether it's a single composite or something more comprehensive? And so it's the maintenance of the case that has to be thought of along with the beginning of the case. In other words, all the stuff at the beginning, how we're going to educate the patient and so on and so forth. And then what we do is we have to have a systematic approach to care. What I call my systematic approach to care is the 1, 2, 3s of dentistry. We have to have a stable starting position, CR, right, consistent and reproducible position, at a workable vertical dimension. We have to know about the anterior parameters, both sagittally, which is function, envelope of function, Posselt's envelope of function, 1951, coronal, smile de jour, and then we have to make sure that the teeth all look like teeth in the posterior. And we have to have a sequential way of doing that. And we can follow that through no matter how difficult the case looks. How do we eat an elephant? One bite at a time. And it's the exact way that we have to approach these cases. Oh, and one of the things I should definitely emphasize here, it's extremely important for everybody to take meticulous records before we get started. Meticulous. And it doesn't matter whether they're conventional, good old alginates mounted on an articulator, photographs and all that, or if people want to do it virtually, you can get your scanner out and scan and whatever way you want to do it. But the records have to be meticulous, because in taking those records, it's more than just the medical legal. In taking those records, we start to visualize and we start to conceptualize what we're really where we're going with these patients and whatever we're going to do in these cases.
Well, you brought up, did you say tech scan?
No, any scan.
But when you say meticulous records, do you recommend any of these high-tech electronic scans? What is it called, a T-scan?
Yeah, I mean, they're adjuncts. They're not doing any harm. Just be careful that you know what you're actually going to do with it. Patients love it, by the way. I would never, just like I said with continuing education before, I would never tell anybody not to buy any technology. But all this technology, I would encourage you to know exactly what your endpoint's going to be. And most importantly, the question I have for you is, what are you going to do if this technology doesn't work? Then what are you going to do? For example, when that aircraft took off from New York a few years ago and they had the bird strike and they no longer had any power, it was a good thing that pilot that day really knew how to fly that plane and landed in the Hudson River. So when the technology, in other words, he knew the basic rules, right, of how to fly an airplane.
You're talking about Tom Hanks, right?
Yeah. But the same thing goes with dentistry. So the technology is great, but if the technology, for whatever reason, doesn't work, all of a sudden we've got a patient that's looking at us, and they're going to be saying, okay, what are you going to do next? Okay, and if we better know what we're going to do next, and it's not a bad thing if we have to go back to conventional ways of doing things. For example, if it's a tech scan, obviously the conventional way is using our hand. The patient doesn't really know what we're doing. But the thing about it is that, just be aware the technology is good, but just what are you going to do if it doesn't work, or you're at a dead end? Again, that tunnel vision. Make sure that there's more than one way to make chocolate cookies. Okay, you can add different things to chocolate cookies when you're making them.
You said something very interesting. Like, I remember when Diagnodent came out, all the old timers were saying, well, hell, I can just look with a mirror and explore. I don't need a Diagnodent. But the patient, it was very powerful.
Oh, definitely.
Putting it over the cavity. So tech scan, and by the way, when I talk about products, I have no financial relationship with them. They're not advertisers. This isn't a commercial. But do you think it does have a high wow factor with patients, or not really?
It gets their attention. Again, it's the wow factor is the clinician that believes in it.
Okay, this is Dentistry Uncensored, so I want to ask you.
Howard, just like you're a great public speaker, and I'm sure that
you must have never heard me.
Oh, but I know you are. I know you are, because I heard people that have told me about how you speak. Okay,
were they drunk and Irish?
and I can almost guarantee that one-on-one with a patient, you've got an amazing rapport. You've got great body skills, or great communication skills, and if a dentist really believes in what they're doing, whether it's evidence-based care or whatever we're talking about here today, the patient can actually feel it. They can see it in our jugglers. They can see it in our face. We're usually got great eye contact with the person. It just exudes confidence. They can see we're confident about it. So the patient buys into it, the placebo effect, everything else. It kind of goes back to what I said earlier. The explanation is the key to all this. And the treatment is just, these things are just tools to get to the end result that we're trying to do. So if somebody wants to use a T-scan, go for it. The key is that as long as they end up getting the end results that they want, and they end up with a happy patient. And a happy patient, by the way, is isn't it true, Howard? Patients talk with their feet, right? All customers, I'm a customer in hotels and that. We talk with our feet, or a restaurant. We either walk out and never come back, or we walk back in one day. So every time a patient keeps on walking back in, we're the best dentists in the world, right? As in their eyes, we're the best dentists in the world. And so if we can get the end result, big smile on their face, and most importantly, they're referring patients to us, why change?
Yeah, and to you young kids, I was talking to a very young girl yesterday, and she was really, really sad that one of her patients left and went to another office. And I got to tell you, after 30 years of this, she might have gone to another office because that's where her husband goes. It might have been closer to her work. It might not even have been you. She maybe just didn't like another team member. You can't take that stuff personal, because humans are so damn complex. Look at you. You try to say that you're all for oral health, but then you watch hockey where all they do is knock people's teeth out all day. How do you morally justify that in your head to support beating your teeth out and oral health care?
Howard, I'm a businessman.
you support hockey to drive business. This is Dentistry Uncensored, and we've all heard dentists say things in restaurants and bars, and I want you to opine on them, because I hear it a lot. They say things like, how does occlusion even make sense when we send all of our kids through the orthodontic factory, and they level and align the Curvis Fee, the Curva Wilson, and they don't really leave it in great occlusion. And number two, a lot of times when people have TMJ, oral facial pain, the orthodontist is saying, well, the best way to get out of that is we'll put you in braces, because we'll let your condyle relax, we'll straighten your... They say this. They say, if I straighten my arm, my elbow determines where my hand is. But when your teeth come together, your elbow's just wherever it's left up. So I'm going to balance your elbow with your hand, and the best way to treat TMJ and occlusion, oral facial pain, is put you in ortho. Then a lot of the referring dentists across the street say, dude, you blow out the Curvis Fee, the Curva Wilson, and you don't even equilibrate them at the end. So that was a lot of ranting. What did you find any good questions in that rant? Anything you can opine on?
Oh, definitely. It all goes back to the famous Gibbs and Lundin study. Remember the study that was done where they studied chewing and how people chew? And it was back
I
in the
must have.
1960s and 70s. And what they did, I'll say it real fast. What they did is they got people chewing, and they hooked them up with the leads in the day into mainframe computers, and then they took the data from the mainframe computers, took whatever articulator it was, hooked up motors, mounted casts, and then watched all the chewing actions. So what they did is they first analyzed people with different worn occlusions, et cetera, and they saw, the various chewing motions, whether they were straight in and out or more of a grinding motion. And then what they did is they then restored them and saw what the different benefits, positive and negative, were. What also came out of those studies, and other people have supported this, or at least found these as well, is what they started to quantify, not just qualify, but quantify, was that for the most part, and I've been even watching you since I started thinking about this when you were just talking to me about it, is most people have their teeth apart during the day. The only time teeth come together is when we bite down for a split second, and or maybe we bite through food. If I'm eating a banana, it's unlikely that I'm biting through and hitting my teeth. So at the end of the day, wear is, for the most part, wear on a dentition is abnormal. And so if a person's got, you're going to love this one, if a person's got their teeth apart, guess what? Occlusion is irrelevant. Okay? So if I can educate my patients to keep their teeth apart during the day, and they wear a piece of plastic at night just to protect, whatever we got inside there from moving or destroying it or whatever else, then for the most part, it's a mute discussion. And so that now we go back to, you're talking about going back to institutes and all this sort of thing. After I spent a lot of money, millennials out there, listen to me, after I spent a lot of money trying to learn all this, which I did, and many great mentors that I'm honored to have been associated with and to learn this. But when I finally realized what I just told you, it was a very humbling moment.
And what's, like, when you said, you mentioned Donald Duck and you mentioned Cookie Monsters, and you young kids have to realize that all those initials after your main name mean nothing to the patient. It's how you communicate, how you make them feel. And the guys and girls with an awesome chairside manner that can, even Einstein said, you need to explain things simple, And if you can't explain it simple, you probably don't understand it yourself. And
there was just a quote in the Vancouver Sun this morning, our local newspaper. We just had a provincial election, our state election, if you're in the United States, our provincial election. And we have a minority government. But anyways, one of the candidates that's going to help form the minority government right now, he was asked about some initiative that they had put forward. And he said to himself, and he was being asked about it, he says, well, it's quite complex to explain this. But he said, it's a good initiative if I can explain it simply and my grandmother will understand it. And I thought, what a great quote. It's so true. If I can't explain something simply to my patients, if they're an adult, that their teenage child can't understand, then that's not good.
Back to millennials again, because seriously, almost every email I get on my podcast is they're either in dental school or they just graduated or they're working as an associate. When they go to the big dental conventions, all the crown and bridge courses are full mouth rehabs, and they come out of school and they got to learn how to do just a basic filling and a crown. And if you look at the lab data in the United States, 96% of the crowns go in as a single unit. And when you look at the insurance data, all the treatments done, there's just 4 huge spikes on the 6-year molars. And so back to the basic rules of occlusion. If you're just some kid that got out of school or you're in dental school and you're just doing a first molar and you're doing crown and bridge, what are the basic rules of occlusion or red flags when you're doing a single molar with a triple tray and an impergum impression? Is there anything you can add value to the simple stuff on their journey before they start doing full mouth rehab someday?
If it's a single tooth, just do the single tooth. Don't mess with the other teeth, because the person's occlusion is stable. We're assuming now, okay, occlusion is defined as the static relationship of teeth. This is occlusion. This is occlusion. Okay. When I'm thinking of occlusion, I'm thinking of the stomatic-gnathic system and a physiologic position, which means, so assuming that the person's got their teeth together, if we only work on one tooth and we don't touch any of the other teeth, even if the person says, oh, this, if they only do the one tooth, that could be the only thing that goes right or wrong. And then just be a meticulous dentist. A single tooth, do exactly the standards of care that we were all taught in university, and it should go just fine. What I do want to add about, you were talking about, the crown and bridge courses and everything else. Kind of going back to what I call the 1, 2, 3s of dentistry. Occlusal equilibration just isn't a subtractive procedure. It's additive too. And so composite makes everyone an oral rehabilitationist. So my favorite provisional restoration is direct composite. So I do a lot of composite rehabilitations. And composite rehabilitations do a number of things. They're cost effective, they're durable, patients can afford it. Even patients without insurance can afford it, or they can be, it's not like it's $50,000, it's still expensive, but they can be, it can be financed in a way that they can afford it. And then it's a template that we can copy exactly, whether we do intraoral scanning to take images of what's working in the mouth, or doing it conventional ways, because there's conventional ways of copying it, and it becomes very, very, very predictable. The other thing that's nice about doing composite rehabilitations is even if the patient leaves us, adios, Miguel, even if the patient leaves us, all we've done to another dentist is the composite buildups. And so from even a medical legal point of view, it's definitive care in terms of a direct restorative material, but these patients are usually going on to either gold or ceramics or something like that. And it's a great interim restoration. And for you millennials out there, it's a great tool to try to get to master. And then you can slowly segmental. The word was, Howard, you remember this one, segmental reconstructions. What we meant by segmental reconstructions is then taking our provisionals and segmentally converting them into definitive restorations, i.e. zirconia, porcelain, whatever you want to do, gold, whatever you want to do.
So let's go to your third book, The Basic Rules of Facially Generated Treatment Planning.
Oh yeah, that's everything. That's the old, Howard, you know this one. That's the old mantra, the old prosthodontic mantra. Meet the person, meet the face, meet the mouth, and meet the teeth. Meet the person. We have to know what the person wants, and so on and so forth. Meet the face. There's aesthetic dentistry and there's cosmetic dentistry. And aesthetic dentistry and cosmetic dentistry are two different things. Aesthetic dentistry is working with the person's natural beauty. Cosmetics in dentistry means whitening teeth, diamonds in teeth, and so on and so forth. So cosmetic dentistry can't always be made aesthetic, but aesthetic dentistry can always be made cosmetic. So what we mean by that is as follows. If nail salons are very popular right now, so got tons of them here in the Vancouver area, and I usually, like when I'm walking by, I usually slow down and I'm amazed at how full they are. But I can see all the therapists there, or the nail designers, or whatever you want to call them. I can see them working and sculpting the person's nail. They're working with the person's aesthetic, and then they put the cosmetic on. If that same person was to go to the local supermarket or wherever and buy the nail and just go, they would get the cosmetic, but it might not look aesthetic. So aesthetic dentistry should just melt into the face. Should just melt into the face. It's done facially, just to melt into the face, no matter what cosmetic the person wants. So if the person wants to go from a dark shade to toilet bowl white, if it's done aesthetically, it doesn't look as in the face as if somebody just goes in and it goes from a wax up 1M1 shade or A1 or B1 or a super white shade and bang, and it's when the person smiles, all you see is teeth. So that's what we mean by facially generated treatment planning. So we meet the face, and usually with the face, what helps us design it is facial thirds, 1, 2, 3, vertical dimension. We then meet the mouth, and meeting the mouth, it's got a lot to do with the skeletal position. Are they skeletal 1, class 2, class 3? It helps us align the vertical dimension, and then we finally meet the teeth. And by meeting the teeth, we just get in there and make sure that we're good restorative dentists. Can all
Man,
be down.
you're an amazing instructor, but you still didn't answer the main question. Do you pay $5 extra to have the sea salt rubbed in your calves? I mean,
Why
they
not?
always ask you every time, do you
There you
want the
go.
sea salt in your calf?
Sounds,
What's
sounds
that?
good. Sounds good.
Sounds good. Will that help with the occlusion if after I get done doing the cosmetic dentistry, I ask them if they want to upgrade for the sea salt?
Why not?
Why
If
not?
if that's the vibe in the office, why not?
So then you go from
I never knock success, Howard.
in your fourth book, The Basic Rules of Being a Dental Patient.
Yeah, that book was when I wrote the first book. Why I wrote the first book, what motivated me was right off the bat. When we started this discussion today, was it occurred to me that we needed a Dentistry for Dummies book, and what I noticed was all these institutes and GPs trying very hard to learn various techniques and everything else, and I just wanted to distill down what I thought were a lot of common concepts like we've talked about right now. I was asked to write the second book by my publisher. He wanted me to do something on occlusion. And then the last book, Facially Generated Treatment Planning, came from my study clubs, because when I'm actually teaching hands-on, we talk a lot about facially generated treatment planning. So in hindsight, I kind of just fell into all of this, and they really should all be blended together, the three books. But that all being said, my patients, when I came out with book number one, they always ask me, could you write a book for us? And so the book is actually written, the fourth book is, I've actually written the book as if I'm a patient. And as I alluded to earlier, I'm 60 years old. I'm starting to use medical services now. And so the book is written as, what do I look for when I go for medical services? Who am I looking for? And the book is about being proactive, and it's about trying to educate patients on how to look at the internet and possibly getting some more scholarly type education by utilizing services such as PubMed.
It's really weird because I'm at a crossroads on water fluoridation. I've almost, the businessman of me tells me, listen to the people. 1/4 of Americans think it's just crazy, communist, toxic, everything's wrong with it. And those people, that's why the internet is frightening, because if I go to the internet and type in water fluoridation, what percent of the sites are misinformed, scare tactics, sky is falling?
I would think a lot.
It's 95%.
Yeah, I would think a lot.
And then when you say, well, you should just go to websites like PubMed or the CDC or Mayo Clinic or Cleveland Clinic, they always think those are a conspiracy. The CDC, well, they're in bed with the government, and the government's taking kickbacks from the fertilizer manufacturers, and the fluoride's so toxic they can't put it anywhere, so they bribe the government to pour it in the water. And it's like, you can't even have a conversation on half of these topics with 1/4 of America.
You want me to respond?
Yeah.
I always try to do a positive spin on things. And so rather than tell a patient, for example, they're a slob and they don't do their hygiene very well, I don't say, geez, if you don't do this, this is going to happen. I try to highlight the benefits. The benefits of flossing is less bad breath. Possibly if you do a little bit of more of this, you get less decay, the benefit. So if somebody was to bring up a topic like mercury and silver fillings or fluoride or something like that, suggest is, for example, with silver amalgam, I say it's been a loyal material. We've gotten a lot of good results out of it over the years. It's a controversial subject. I know it's an emotional subject. I would encourage anybody. I never go you. Oh, by the way, you is always a bad word. There's the camera. You is always a bad thing to say. I always try to talk in terms of I and we. So I would say that what I would encourage myself to do if I was doing this is I would try to go to many sites as possible, and then I would sit back and think about what my value system is and my family value system is, and I would weigh out the options, what I think is best choice to make myself. So it sounds like I'm basically telling the person, do whatever you want, but what I'm doing is I'm trying to plant seeds in a positive way that possibly there might be some information out there that they might find enlightening, that might sway their opinion a little bit more. We all know the Rogers adaptation curve, don't we? The Rogers adaptation curve is how people move along with concepts. We have our innovators, which are out here. It's a bell curve. We've got our innovators out here, which are usually considered the idiots. They're considered the wackos and the nuts. We've got our early adapters. They're the ones that see a really good idea and jump onto it. So for example, you have your innovators out here. Maybe those were the people that were thinking about personal computers 40 years ago. And then you have your early adapters, and they say, oh, wait a second, these, maybe Dell would be a good example. Oh, we like these personal computers. I'm going to start making all kinds of personal computers. This is going to be a good thing. And then you have the top of the curve up here, which those are the people that tend to say, okay, this looks like a trend. We're going to be riding along it. Then you got your late adapters. It's like, oh, damn it, I guess I do have to buy an iPhone now. Everybody else has got one, and damn, I don't really want to do this, and I better do it. And then you have laggards. Well, we're always going to have our laggards. I mean, we're always going to have our laggards. And so even when it comes to topics, no matter how emotional people might get about them, we're always going to have people that are going to not even be interested at all, unfortunately.
And what percent of Canadians and Americans do you consider to be just batshit crazy?
It depends what you're talking about.
So when you go to your website, drracich.ca, Dr. Racich, RACICH.ca, you have 4 sections. You have Focus Dental, Dental Coach, Second Opinions Only, Media Publications, which has the 4 books. So let's start one by one. What's Focus Dental?
That's my continuing education. That's my hands-on programs. So Focus. I run study clubs. I like running study clubs. So those are getting groups of dentists together, and then we run it. First couple of years are run very structured, because talking about topics like you mentioned earlier usually takes a very structured approach to go through things like what's the joint position and vertical dimension and all that sort of stuff. So the first 3 years are very structured. So that the first door explains how I run my study clubs. They're hands-on. We get groups of dentists together, and
are these all mostly in Western Canada?
They're mainly in Western Canada, but they can be done anywhere.
And how many sessions is it usually to get them from A to Z?
The first year is basically what we talked about earlier: centric relation, records, making an orthotic that we can get into the mouth predictably at a predictable vertical dimension. So the first year is 6 or 7 sessions. And we space them out about 2 months, 6 weeks, to give everybody a chance to go back to their office, think about it, so on and so forth. The second year is facially generated treatment planning. And what we do in the second year is we do a denture. Because the easiest way to learn facially generated treatment planning is put something in there where we can move the teeth around very easily, lip support, jaw relationships, and so on and so forth. And then what we do in the second part of second year is the dentists mount a set of casts at a workable vertical dimension that they want to work at, and then they do a wax up or a composite up on there. Just to give them an idea what the stages would be to literally reconstruct somebody's mouth, applying the basic applying facially generated treatment planning, and then we just keep on going on for there. My first study club is still going. We've been going for 19 years.
Wow. Now, Phoenix, I don't know if you got to be aware of this. 10% of Phoenix is from Canada.
Oh, easy.
Yeah, 10%, and they're the only ones that.
The winter might even go as high as 50. You never know.
My God! There's more maple leaf flags flying in the retirement communities than there are American flags, because it's their way of communicating to each other. Where they're at. But anyway, in fact, both of the orthodontists across the street from my office are both from Canada. But if it's 6 or 7, it's 6 or 7 classes a year, 2 years.
No, each year is about 6 or 7.
Yeah, but it's basically 2 years long though to get through all your.
No, well, it usually takes about 3 years. Okay.
Well, I'm just saying if you ever consider doing that in Phoenix during the winter months. Of course, you don't really have winters because you're in a rainforest, right?
That's right, tropical, a temperate rainforest.
Yeah, most people don't understand this about Canada, but it's Vancouver. You got to go on the Alaskan cruise. It's the only same cruise I did twice. I mean, Canada, where you live, is a tropical rainforest. What is it, like 80 inches?
Temperate rainforest.
Temperate rainforest. How much rain do you guys actually get?
I don't really know how much we get a year, but it rains. But it mainly rains. Well, we get rain all year, of course. The heavier rain is November, which is bad news. But then it's good news is because that's when all the local hills around us and Whistler, our big resort, get all the snow. That rain in the wintertime brings snow to all our ski resorts, which is really nice. And in downtown Vancouver, we get snow in the city, but not a lot of snow. Most of the snow stays up on the hills. So year round, people can golf, that sort of thing.
And then tell them about the third part of your site is Second Opinions Only. What is Second Opinions Only?
It's mainly a site for medical legal. I do medical legal work. Plus, I'm on the College Inquiry Committee, the Discipline Committee, so I do medical legal work. But the Second Opinions Only is actually just that too. It's for any dentist that wants to send me some various cases or whatever, or it's also for the public. So if a public just wants an opinion on what to do, it's strictly an opinion. I'm not soliciting work. In fact, anybody that comes through that site, any patient that comes through the site, I won't take them as a patient. I'm strictly there to give them an objective opinion, give them the facts, let them go away and think about it, then hopefully seek care with their dentist or whatever dentist they choose. I want to go back to how many years it takes to do the programs. Clearly, study clubs in Western Canada run from September to June, and so that's why it kind of gets the 6 or 7 sessions get kind of expanded out, if you like. But clearly, these could be condensed. I mean, the 6 sessions could be condensed into 1 month. So that whole 3 years, for example, could easily be done in 1 year, 3 months. If it was a graduate prosthodontic program, that would be it would be vacuum packed, very tight.
Interesting. Man, I think you're amazing. I hope you make some online C courses. Well, Dental Talent's interesting. So we have an annual meeting where we meet every year. The first 15 years was in Vegas, and then we planned the next 2 years, the next 2 Aprils to be in Orlando. But you can't really have a department that has one meeting a year. So the only way it works is you got to have other meetings during the year. So we have that big annual meeting, but now we put other meetings on. We like to put other meetings on, and of course there's 4 million people in the metro of Phoenix. So when we put courses on right here at Dental Town at the Indian Reservation Casino, I mean, shit, there's 3,800 dentists that are in driving distance just to that course. So I know you Canadians love Phoenix. My gosh, you love Phoenix. It's funny because if you're from Canada or the northern Midwest, you come to Phoenix. But once you cross that Mississippi River, you go to Florida. Yeah. And I don't know if there's, but yeah, this place it's so Canadian. That's why I thought you might want to do that. But man, I hope you make some online C courses. Can I ask one overtime question? Because I've been looking at the message boards under TMD, and there's one reoccurring question that is the biggest frightening ghost and goblin in all of occlusion, and that is if they open up someone's bite.
Oh, no. Don't worry about opening up anybody's bite. The most you're going to, most of the dentists, okay, obviously we've got the denture cases where they're like that, but dentate people usually don't come in. And so our jaw is like a nutcracker, and it's 1 millimeter here is about 3 millimeters here. So if we've got even a class 1 occlusion, and we open it up 3 millimeters, that gives us a lot of room for restorative materials. If we open up the posterior 2 millimeters, that's 6 millimeters. The clinical height of a central incisor is 10 millimeters. If we've got a skeletal class 2, because, and by the way, when the jaw opens up, the jaw just drops down. It doesn't drop down, the jaw auto-rotates back. So if we've got a skeletal class 2 person, where am I in this camera? A skeletal class 2 person here, I mean, they're going to even auto-rotate further away. So the amount that we have to open someone up, we're talking a millimeter. A millimeter is like nothing. 2 millimeters is like, whoa. 3 millimeters, oh my God. We just don't do that. So opening up a bite is not a problem, okay? It's making sure we have a stable position, and again, what I call the 1, 2, 3s of dentistry. And then, and if you think about it, if we really stop and think about it, if someone's got a 50% overbite, and we continue to work with them in that case, and if by some chance we restrict the envelope of function when they're functioning, they might start pressing against it a little bit more, which might cause a few problems. We might create a problem. If we open up someone's bite, one of the things that we're doing is we're giving them a little bit more freedom. What we're also doing is if they're bruxers, we're giving them less porcelain to smash. So opening up a bite isn't such a bad thing to do. It also makes people look a little younger. It's almost like free Botox. Help get rid of the wrinkles. And it comes back to this facially generated treatment planning. So when we're treatment planning someone, we're looking at the facial thirds, and we're looking at what their lower facial third is, and can we open them up a little bit? And depending on their skeletal class, we can get away with a little bit more, a little bit less. Class 3s, we can get away with quite a bit because of the edge. Class 1s, we can get away with a fair amount. Class 2s are a little trickier. Skeletal class 2s, depending on how more, where they're at and all that sort of stuff. But it's not insurmountable.
And just for a total disclaimer, I want you to know that I have not used Botox. This is all natural. This is totally natural. Everybody thinks I photoshopped my face, but it's all natural. Hey, man, I could listen to you for 40 days and 40 nights. I think you're the bomb. This is a very, very difficult subject. It takes a long time to learn it. I think you're, I can't believe you wrote 4 books. You are so prolific. I mean, God, that's like having 4 kids on the side.
There you go.
Yeah, but man, seriously, thank you so much for coming on my show today.
Sure, thanks for having me on board.
And I do think if you did a 1 hour...
Thank you, everybody out there, for listening to me, too. Hope you haven't shut off halfway.
I think that if you did a 1 hour online CE course on each one of your 4 books, it'd be the best marketing you could do for those books.
I'll do it.
Yeah, okay.
Let's get her done.
All right, next time I see you, I hope we're having a beer at a bar before I get on that Alaskan cruise again.